Hi, and welcome to Aesthetic Skin and Surgery. I'm here with Dr. Igor Chaplik, and today we're going to be asking Dr. Chaplik questions about perioral dermatitis. Now, if you happen to know anything about perioral dermatitis from experience, or you would like to know what this perioral dermatitis is, I can describe it as a rash that commonly occurs around the mouth area. Sometimes the skin can be very flaky, sometimes it can look like little red bumps, it can feel irritated, it's commonly mistaken for acne, and it doesn't just occur around the mouth, it can occur around the nose, as well as even around the eyes. Am I correct?
You're absolutely correct. I like to limit the description of perioral dermatitis to rash from the nose down, simply because they're actually related. Rosacea and perioral dermatitis, in my mind, is the same condition, except that the perioral dermatitis typically stays under the nose. There's less flushing and blushing with it, but they're cousins and they're treated very similarly. So if you've seen our special or discussion on rosacea,
yeah, that was our last one.
Yeah, they're very similar conditions and they're treated very similarly, except for the fact that the risk group is a little bit different. And like you said, I think that women are a lot more likely to get perioral dermatitis. And they also come in, like you said, also with a different diagnosis to my practice, where they've been treated by multiple doctors, given things for either acne and allergic contact dermatitis, and just the condition gets more and more aggravated.
Right, and sometimes they've been treated for a long time, even years, for acne.
Acne, or even worse, allergic contact dermatitis. A lot of times patients are given cortisone for this condition, and that's actually the worst thing that can happen.
What is the danger, Dr. Chaplik,
The
in
danger.
prescribing cortisone for something that is not an allergic process, something like rosacea or something like perioral dermatitis?
That's a good question. So there's a lot of dangers, but usually with those conditions, the cortisone helps temporarily, so the patient is happy. They get the cortisone for a perioral dermatitis or a little redness around the cheeks, and it goes away. Because cortisones are vasoconstrictors, that means that they shrink the blood vessels and constrict them.
Wait, so it goes away, isn't that a good thing?
And so it's great until it's time to stop the medication. And then the rule of thumb and the trick with cortisones is they're not for extended use. So I like to limit 2-3 weeks, and if something's coming back each time the cortisone is stopped, that's telling you something. It's not the appropriate medication. And so a lot of my patients come in, they're on heavy duty cortisones, not just like a little hydrocortisone on the counter. They're on some class 1 corticosteroids. And
what does that mean for our listeners?
So there's different strengths of corticosteroids, and the strength is based on a vasoconstrictor test, and it's done. And so the class 1 corticosteroids are very potent.
Are those the highest?
They're the highest strengths, and also very potent vasoconstrictors. That means that over extended periods of time, they can thin your skin and cause permanent broken capillaries and even get absorbed into your body. And those are the dangers of cortisones.
Now that sounds horrible. In case there's somebody listening to this that just found out that they have perioral dermatitis, or might suspect that they have perioral dermatitis, what are the actual names of these potent steroids that they may be on?
So it's a good question. There's clobetasol, the most powerful, and also one of my favorites to use. There's betamethasone, halobetasol, there's strong triamcinolones.
But those are not, just to be clear, your favorites to use for this particular
No, they're
condition.
my favorites to use for very heavy duty psoriasis, eczema, thick plaques. So when patients have thick plaques of rash, the stronger cortisones work better because they can get to the skin. But imagine that the skin is flat and you're putting a very strong cortisone on it, can flatten that skin too and thin it.
Absolutely.
Or in areas of the body that touch. But anyway, I think we're getting off subject with cortisones. Let's get back into the perioral dermatitis, because a lot of different topics to discuss with that. This is a partially treated or incorrectly treated perioral dermatitis. It's its own category. And that treatment, when the patient comes in, is even more challenging than if they have nothing at all.
Because it's been complicated.
When the skin likes the cortisone, it craves it.
Right.
And so when it's time for the patient to stop the very strong cortisone, things go haywire. The skin gets worse, and the rash gets 10 times worse, and the patient gets itchy, uncomfortable.
Do they think you're doing a good job?
They think I'm doing a terrible job because I tell them to stop the medication that had made them better, but at the same time they know something's wrong. They're in my office for a reason, so it takes a lot of counseling and a lot of hand holding, and almost like, what I like to say is, it's almost like heroin for the skin. Those cortisones the skin loves and craves. It's time to stop them. The skin goes into withdrawals. It really wants that cortisone back. And so I have to not only counsel the patient, but give them a non-steroidal medication that helps, and it's something called pimecrolimus, is a non-steroidal anti-inflammatory that I use frequently for this condition because it helps me wean them off, so to say, of the heavy-duty cortisones and start them on something that will help with the symptoms of itch and redness, but at the same time not cause the skin to get addicted.
Now, how does that one work?
It's an immune modulator, so it helps in a different category. It's not a vasoconstrictor, and so it helps differently, and it's non-steroidal, which is the most important thing.
Okay.
It works locally to help with inflammation and things like that.
Got it. Without having to
Vasoconstrict the blood vessels, and it's an anti-inflammatory in different ways. Cortisones are anti-inflammatories and other things, which is a little bit too in-depth for this discussion, but at the same time, we use anti-inflammatory medications that are non-steroidal, and more importantly, that's the most important thing to consider there.
Now, what other medications might you include in the treatment regimen? And
Right.
we'll get to lifestyle modifications in the next video.
Okay.
But for this one, we'll just talk about the medications.
So when they're partially treated or incorrectly treated, I almost always request that pimecrolimus is added because we're weaning off the cortisone and skin wants it, and so that's crucial. Secondly, I use a more appropriate medication for perioral dermatitis, and that usually involves metronidazole, but my favorite is ivermectin topically. It's not the horse paste or the horse pills or the ivermectin that was used during COVID, whether it was good or bad or whatever the controversy
We're
may
not
be.
commenting on that.
No, well, we've used ivermectin for years for rosacea. It was approved maybe 20 years ago in a product called Cilantro, and ever since then, it's become the mainstay and my drug of choice for perioral dermatitis.
You
And
even have it compounded yourself
Yes.
for the practice with other beneficial ingredients.
correctly, and I use it for rosacea, and sometimes it's not covered by insurance, so for that reason, we carry it in the office as a inexpensive alternative to go in the pharmacy. But anyway, that's a mainstay in either treatment, whether the patient is being weaned off of cortisone or not. Whenever I see perioral dermatitis, I always try to recommend ivermectin as a cream. Secondly, depending on how bad it is, I use doxycycline, which is a pill by mouth sometimes. Doxycycline treats bacterial infections, but in this case, it works very well as an anti-inflammatory, a non-steroidal anti-inflammatory by mouth. So doxycycline is a very potent non-steroidal anti-inflammatory, and it helps drastically with these types of conditions, whether it's perioral dermatitis and or rosacea. So we use it in this case not for antibacterial properties, but more for an anti-inflammatory.
Okay. And that's something that you also use for acne patients too, right? So
Correct.
I can see how, maybe a patient was diagnosed with acne, and their previous provider might have had them on doxycycline and a few other things that were acne targeted. What happens when a patient with that background comes to you instead of a patient that's been on steroids?
It's a good question. Typically, it doesn't happen that often because of the age group. So usually the age group is women in their 30s to 60s that get this, and typically the provider is keen enough to realize that it's probably not necessarily acne, and perioral dermatitis is sometimes scaly and patchy. And so the doctor, the provider that treats them typically thinks it's allergic contact dermatitis, a little rash, a little irritant, sometimes an irritant from using retinol or Retin-A. But when they are treated for acne, they do tend to do a little bit better. But without the ivermectin and the metronidazole, the condition seems to get worse and worse and worse.
Okay.
So even though the doxycycline is good, the topical regimen sometimes aggravates the skin barrier, which is also very important in perioral dermatitis, and so they get dried out and irritated, and it gets worse. And so what we failed to mention is, on top of the fact that I like to give doxycycline, ivermectin, and sometimes metronidazole, I have to repair the skin barrier, and so that involves gentle cleansing with either Cetaphil or CeraVe, and also a daily facial moisturizer with a sunblock in it in the mornings.
Great. Okay, well, I think that our conversation is beginning to move into lifestyle modifications and different things that we can do to help prevent perioral dermatitis if we're somebody that might have a history of this or be prone to it. So I think we can end the conversation here before moving into that next subject in our next video. Is there anything that you would like to add on the medication treatment plan front in this discussion?
I think we did well. I think that just a rule of thumb is, if you're using a medication and the second you stop it, the rash keeps coming back, then it should probably spark some kind of investigative, curious type of discussions, and maybe ask your provider or your doctor to kind of look into some other things that may be going on, because using cortisones for extended periods of time is probably not okay unless you're doing it with the doctor. And so if the doctor sends you home with a tube of cortisone and you've been using it for a month or two and the rash gets better, gets worse, gets better, go and pay a visit and say, I've been using this frequently, is it okay? Is this what it's supposed to be doing? Is the rash supposed to come back?
Right. Or even consider a second or third opinion.
Well, let the doctor figure it out.
Okay, all right. Go with your gut.
Yeah.
All right, words of wisdom. Thank you so much for your time, and I look forward to speaking with you again shortly about lifestyle modifications to help prevent and to mediate perioral dermatitis.